I have one that I'd like to just clarify. On item 5, page 12 of the minute, the strategic risk register, we're heading towards a workshop on that in October, and I think it was important that one of our committee members, Councillor Bell, for yourself, to meet with officers, and you'd also kindly shared a circulation for us in the meantime. I just want to make sure that actually happens before we get to the workshop. Can somebody indicate whether that's happened or in train?
No, that's actually happened. I had a quite a useful chat. So yeah, that's good for me. Thank you. And so the information I forward is being digested, and hopefully it'll actually make for a productive workshop. Thanks, Chair.
Thank you very much, Councillor Bell. Okay, so there's just a couple of typos, and I'll raise those with Derek, just so that bit's tidied up. Otherwise, we're content with the minute. Okay, if we can move on to item 4, which is the business planner, pages 17 and 18. Alex, did you want to take us through this?
Yeah, I can do, Chair. Yeah, we've got only got 2 reports on the agenda today. The Audit Scotland report, we only bring if there is activity in that regard, and over the last few months there's not been the same level of Audit Scotland reports as they would normally do throughout the year. And then the second thing is the review of the Code of Conduct, and we're going to bring that back in November. And the legal team are working on that. For the next meeting, you've got, there's the list there, and we're working our way through that as it sits at the moment. I need to have a look at the finance side of things in terms of whether I maybe bring that in November as well, but that's something that I'll need to see once I get the financial results through to determine where best that might sit, whether it be the IJB or the Risk Audit and Performance Systems Committee. So the rest of the stuff is we're working our way through, and I guess one of the things that we're potentially seeing at the moment is that in terms of this agenda and maybe even the next agenda, is we're seeing that we did a lot of business through the IJB and so on, but some of the recurring business that normally comes to Risk Audit and Performance is taking a bit of time just to start picking up again, whether that be the Audit Scotland reports or the reports from our internal audit colleagues.
Mm-hmm. Okay, thanks very much. Yes, that point about the finance monitoring, so it'll either come to the IJB or to ourselves, because end of September you'll have the half year through. That's good. Thank you. Any comments or questions on this? Okay, I'm not seeing anybody signalling, so that's fine.
Chair Luan has
here. Oh, Luan. Yeah. You're on mute, Luan. That's you now, I think.
Okay. It was just a question about hosted services and whether the annual reporting will come through the RAP committee, or has there been a decision on where we'll see hosted reporting, Alex?
Not as far as I'm aware of at the moment, about where it is. It was certainly last time we took it through in a workshop environment at the IJB, and we had a kind of covering report at the IJB in that regard. I think one of the chief officers are looking at this in terms of how they get that assurance over to the IJB. So it's certainly been worked on, but in terms of where we actually take it to, no decision at the moment.
Okay, thanks.
Okay, thank you for that, Luan. And so, Derek, if you can just minute that question was asked, and then that will come back to an appropriate meeting. Okay, thank you.
Noted.
not seeing anybody else signalling, so if we can then note the business planner, thank you. And that takes us to item 5, which is the directions report. Again, Alex, if you can take us through this, please.
Yeah. So the directions are the way that the IJB does business. Really, we can't really commission things through the IJB, and therefore we have to direct our partners, which are the council and the NHS, to go and commission and deliver on directions on our behalf. As an IJB, we're probably one of the first IJBs in Scotland to kind of really use the directions, and we've kind of moved forward on that basis. We also developed a process for for tracking directions and so on. And one part of the process that we hadn't really completed was that bit in terms of the report back. So this report, reports back on what's happened with the directions as it sits. I would say, well, that this is like stage 1 in this sort of process, and there may be further improvements that need to be made in this regard, and that's certainly something that we'll take comments back from the committee and seek to deal with that going forward. But I think this is actually quite a useful document in terms of it gets us to a point where we close down some of the directions that are there, so that we're only concentrating on reporting back on the directions that are still live and still in a force. So when we went through the document and the directions tracker, a number of these directions are annual directions or directions that are superseded in future years by other directions. So we were able to kind of close them down, and largely our directions have been around about our transformation programme or commissioning or our budget. We haven't actually had any directions at the moment which are non-financial, but there is a chance that at some point in time that we may need to direct council or the NHS to do something that doesn't have a financial consequence, but as a kind of policy kind of context. So from here, we went through these, and we categorised them as complete or ongoing, and the ongoing ones are still valid and still being operated on it, and we're still working our way through them. But the complete ones are either complete because the date's expired, or there's been another direction that's superseded them and effectively closed that one off. So I think what we've now got, Chair, is a useful starting point, and I welcome comments from the committee so that we can improve our monitoring of this in future. And then that'll certainly be helpful for officers, because having to kind of monitor on the number of directions that were in play at that point in time would have really sucked up a lot of our resource. But if we could just kind of stick with the ones that are ongoing, then that will be helpful.
Okay, thank you very much for that, and thanks for the work to bring it to this stage. I think that's helpful. So can I just open it up for comments and questions, please? Councillor Samurai.
Thanks, Chair. I found it a terribly useful document to see all the directions that have come through, and thank the team for putting that together. One of the things I was curious about is, for the directions that are still ongoing, I noticed that there is some narrative for some of them and not for others, and I just wondered if I could have an explanation of why that is. I mean, it might be something as simple as, there's nothing more to say than it's ongoing, but I mean, if I could get some clarity around that point.
Okay, thank you, Alex.
Yeah, so on some of the ongoing ones where I had some information relatively easy to hand, then I put in some narrative around that, particularly the ones that are funded from PISA. Really what we've now got to a stage of is our ongoing ones are really our commissioning, as in the commissioning stuff that we do on a regular basis, and it's just kind of rolled into our business as usual, or the things that are in regard to the kind of transformation projects that are still ongoing. And by transformation projects, I'm talking about now, I suppose, PSIP, Action 15 and ADP. So the majority of the rest of that stuff is now kind of mainstreamed and just making its way through our normal processes. But that's the ones that are there. Going forward, what my intention would be to have more narrative on the ongoing ones, so that you could, you know, get a little bit of an update around about that. But what my fear was in terms of how it's actually set at the moment is that when we send this out to officers to seek to update, there's just so many of them that they don't know where to start. So certainly in future, I would be looking at having a little bit more detail around the ongoing ones, and the ones that I have been able to put some detail behind are ones that I was aware of or I'd searched up because I was interested in them myself. So certainly a good point from Councillor Al Summarise, and something that we'll pick up on in future iterations.
Okay, thank you.
Thanks for that, Chair. I mean, I think, as you said, it's a really good starting point. It was very useful to see that, and it's good that we've been able to close off some of those directions, so that when we see future drafts of this or future reports from you, that it's only the ongoing stuff that we'll be looking at. So thanks very much for that again.
Okay, Councillor Bell.
Thank you, Chair. So an observation and a question. So the observation is the first two rows have been repeated on the directions charts. Probably feels like you've been doing lots of work, Alex, but yeah. So that's for implementing the integration scheme. See that.
So that one. So the first two rows, I think one is to, and it's not mentioned within here, and again, well, that was because it was the first direction that's ever there. But one was to NHS Grampian and one was to ACC. So basically, the first one was a direction to ACC to deliver on the IGB would deliver on the scheme of integration that had been agreed, and then the other one was to the NHS Grampian to do the same. So that's a little bit, it's not particularly clear in the document as it sits at the moment, but there were two directions there, and these ones are still ongoing. And I suspect what we'll do is we'll keep these ones ongoing until we revise our integration scheme, and then once the point at the time where we revise our integration scheme, well, we will close off these two directions and then move into a new set of directions, which will be agreed at the same point that the integration scheme's agreed. So that's the background to that one. But they're the two longest standing ones, because that's what the IGB is about, delivering the integration scheme, and therefore they're still live at the moment. Some of the information in regard to the earlier ones, we were just getting the process right at that point in time. So some of regard to the earlier ones maybe aren't quite as succinct as what's got further down, because at one point, at that point in time, the process that we've developed just now didn't exist.
So the eighth column, the colour-coded one, indicates whether it's NHS or ACC. Was that the question that you had, Councillor Bell?
No. I hadn't actually spotted that, because I said that both. I said that there were two rows that were repeated, Chair, and I understand what I didn't actually spot the ACC nor the NHSG, but Chair, if I look in the the fifth column, they've both got the same task number, which is IJB 160416.
Isn't that the date it was approved?
Yeah, that's the IGB.
2016.
Yeah, that was the IGB it was approved at. That was the first IGB.
Oh, right. So, okay. Well, okay, that was a daft bloody question. It really was a daft bloody question. So my question for you then is, so clearly this is actually detailing services, as we go on with this transformation. can't see phlebotomy. Should I see phlebotomy there? Because that's one of the services, isn't it?
Yeah, I mean, the directions as they sit at the moment, I mean, that one there is like an all-encompassing direction, is what I would say, is these two there cover a number of services, and phlebotomy would be included within there. But the only reason that you would potentially see phlebotomy in this list here is if we decided to do something different with that phlebotomy service, and it required a direction to the NHS Grampian to go and either change or put additional staff in there, and we had identified funding to go and do it. So phlebotomy will be included within that base in the first two, but we haven't actually specified out in that all the services that were delegated through the integration scheme.
Right. So if I could supplemental, please, Chair. So at the moment, I know that there's a phlebotomy nurse at the Colts Medical Practice. You run phlebotomy at the health centre in town, and I think the phlebotomy service in Colts runs very well. You know, locals rock up to it, very convenient for them. And there was a question of integrating that into your main service, which struck me as being counterproductive. So that would be the sort of thing that I might be interested in actually exploring.
Yeah, so phlebotomy has been something that we've been interested in for some time, in terms of where that service sits and so on. And you are right, within the local GP practices, you know, there are phlebotomists at the moment taking blood and so on. And we also look at what's happening within the city, because there has been discussions in the past about centralising some resource to allow you know, phlebotomy to be undertaken at an area where the you know, where the population demand. So if you were in, for instance, in the town centre, it might be useful. If you worked in the town centre and you needed to give blood, it might be useful to give blood there, and then it could be the results of that blood test could be passed on to any of the GP practices within the city. So that's certainly something we've looked at in the past. One of the things that we're looking at going forward is around about some of these services, such as that, and how that would how that could be managed within the locality. So we'll be looking at something called a CTAC, which will take on some services such as phlebotomy. I'm not sure if phlebotomy is in scope of that as it sits at the moment, but certainly that's one of the things that we'll be looking at around about that, and that's funded from the PSIP money that came in, so the Primary Care Improvement Plan funding. So I think there will be information that comes back to the IGB in due course about CTAC, and that, and phlebotomy may well be one of the services that's in there. But I can't say for 100% sure. I would have to go and look back through my files just to double check that, but it certainly is something that we're looking at.
Okay, thank you.
Okay, thank you. Anything else, Councillor Bell? No. Okay. Luann.
Thanks, John, and I agree. It's really helpful to see the directions tracker here, and we're certainly much further ahead than other IJBs. When I hear the discussions around the chair and vice chairs group, there's other areas that are not as advanced in how they use directions. So we're definitely in a very good place. So I've got a comment and then a couple of questions, if that's okay. My first thing is just, it's coming to wrap. How I understand it is it's coming here so that we can provide a bit of scrutiny that directions are being actioned appropriately and timiously according to the dates on that. So I wonder if that's correct, and I think I'm not hearing it's not, that maybe if we looked at the status section, I wondered if we had one that was complete, which is Jill was suggesting that we don't really need to see them, they could be shifted off, and the ones that are in progress, if they could be sort of given a colour coding of, you know, the ones that are green that are just progressing, and then maybe amber or red, so that when it comes here we look at the red ones and we provide some questioning around if something's overdue, why is that, or what the barriers are. And would that be a helpful thing, Alex, to categorise the status in that way, to help make sure we focus on the ones where you know where it's overdue or where there may be challenges?
Yeah, I'm happy to have a look at that. As I say, I've got no hang-ups either way around about what's happening in terms of there. I feel that what we've got here is, you know, a stage one, and if we need to make that change in the same sort of way as adding a bit more narrative, and then I'm happy to consider both these options.
Okay, great, thank you. And then my other two bits are, when I saw this, I was remembering that Scottish Government introduced new statutory guidance around what should be contained in directions in January this year. And I just wanted to check that, you know, so the RAP's looking at whether they've been actioned, but actually is there, how do we get assurance that we're writing them in the correct way and they're containing all the right information? You know, are we using the template from government as a standard guide for how we do them, Alex?
Yeah, I mean, I think the stuff that we had done, I suspect had probably influenced the guidance that came out, to be honest. But the last time I had a look at that guidance, there was very little of it that we hadn't closed off. There may have been, you know, one that I can't remember for what it was, but there may have been one little bit, but the rest of it was, you know, we were on top of it, and our process and template covered the vast majority of what the guidance was seeking. And it is, I guess, it is only guidance at the end of the day. So if it doesn't work for us, then we can decide to go in a different way. But certainly when we had a look at it at that point in time, there was nothing jumping out at me that said we had to change our processes immediately.
Okay, so that's been looked at. That's good. And then my final question was just looking at the ones we've currently got. If I'm reading it right, there's one around pharmacy, which seems to be, I don't know if it's overdue or due around about now, and there's a figure of 316,000 next to it. So I just wanted to understand a bit more what that was about, and, you know, is there a cost implication coming, and is that being actioned?
Yeah, so that one will be the additional support for pharmacy in the GP practices. And it is funded through PSIP, and you are right, there is a date on there that's passed or is nearly passed, and my suspicion is the reason for that is that you know, just pulling back up these services in the IJB around about that. So we are looking at our PSIP again, and that would fall within there, and there would be an approval from there. But there's no issue in regard to the money for that, because it's staffing costs that are recurring, and it's funded from the PSIP budget.
Okay, thanks, Alex.
Okay, thank you. I don't see anybody else signalling. So I just had a couple of quick questions on this. And I see we've got Colin on the call as well, but this was linked to an audit. So does, if I'm remembering correctly, so does that satisfy and conclude that aspect of the audit requirement?
Yes, thank you. It does. I was just to update that on our follow-up system to say that it has been discussed and reviewed. Yeah, it'd be good to see how that develops going forward. It sounds like a good idea to have a sort of exception monitoring if that's what you decide to go with. But yes, this has presented a list of all the actions, directions that have gone out and where we are with them. So very pleased with that. In terms of the Scottish Government guidance, when we did the audit, we did take account of some of the draft version of that guidance. And generally speaking, we were quite happy that was taking place. All the requirements of that were being met. It was generally just tweaking bits and pieces to make sure that we had the appropriate rationale, for example, and this element, which is the monitoring of it. So yeah, we're pleased with that. Thank you.
Okay, thank you, Colin, and thanks.
And that
Alex.
will close off that action.
Yeah, good. And well, thanks, Alex, for bringing that to a conclusion as well. Can I just ask you, Alex, then, what would be your intention in terms of reporting again on this? Is this an annual thing or biannual, or what would you think?
My feeling would be every 6 months. I think quarterly you might not see the movement that you potentially want. whereas I think every 6 months, if the committee were in agreement, that's when we'll be thinking about bringing it back and bringing it in there into the.
Okay, thanks. I think that would be helpful as well, given that you've kind of caught up with all of this, and the next version will have fewer items and that bit more narrative, as Councillor Al-Samarai said, and possibly the kind of colour coding that Luann's talked about. Okay, is everybody happy that that's 6 monthly then from the committee?
Yeah, that's
okay.
good.
And thanks for all the contributions. I think it's important when we get something new like this that we do get our head around it. So all of those contributions have been helpful. Thank you. Okay, if we can go on to, well, in terms of the minute then, Derek, if you can indicate that concludes the audit, if you can capture that aspect as well, please.
Thank you, Chair. The recommendations are that the committee note the contents of this report. Can I suggest that in addition to note the contents of the report, that the committee note the closure of the referenced audit recommendations at the same time, and that this report be returned 6 monthly to the committee?
Okay, that's great. Thank you very much. Yes. Is that accepted by the committee as recommendations?
Yeah, agree.
Okay, thank you.
Thank you.
If we can go on to the next item, which is the transformation. Yeah, I'm just scrolling through this. So the transformation evaluation. So I see we've got Callum here, and he's going to provide a presentation as well on this. Who else is here for speaking to this report?
Alison is also here to answer any additional questions that that the board might have, and one of the other programme managers, Susie Downey, who is responsible for some of the flash reports that are contained within the report, is also available in case there are any specific questions that arise from the discussion.
Okay, thank you. So welcome to all of you for that. So can I hand over to you, Callum? Do you want to go straight into this, or does Alison want to say anything first?
I'm happy to go straight into it, and as you stated, I've got some slides which I thought might be helpful for context to describe the paper, and then we can open it up for any further questions if the board have anything additional they would like to ask.
Okay, thank you.
Okay, so I will just I'll just share my screen just now. And really the purpose of this is it's a brief overview looking at how we evaluate our transformation, thinking about how we've done this in the past, thinking about how this might need to change moving forward. So the first thing that I wanted to do is provide a little bit of context as to the situation that we find ourselves in. So you will all be aware that when we think back in February, we had our 5 programmes of transformation. We had a variety of priorities that were encapsulated within them. We obviously had our medium-term financial framework, which contains some of the objectives from the leadership team. And we, of course, had our performance data dashboard, which I'm sure you're all very well versed in, which helped us evidence the cumulative impact of all of these priorities. Fast forward to March, we all know about the COVID situation, and over the subsequent months, we had a variety of transformations that we embedded during the COVID period as a response to that pandemic. That was things like our scale up of Near Me, moving GMEDs into the health village, and increasing our hospital home capacity. So more recently, we've obviously been in this scenario whereby we are living with COVID, and as such, as a partnership, we have refreshed our priorities in terms of what do we need to do moving forward. Now, some of these priorities are actually previous priorities from February, which we had to pause so we could focus on our COVID response. These are delineated within the paper themselves, and of course, they already align to our performance data dashboard, which you've all seen previously. So what I propose to do, rather than going through that in any great detail, is to give a little bit of focus on maybe some of our emerging priorities that are as a result of living with COVID. And these fall under the portfolio of Operation Home First, which is going to be the focus of what I'm going to speak about today. So this slide basically shows the strategic context of Operation Home First. This is a cross-system collaboration between Aberdeen City, Aberdeen Shire, Moray Health and Social Care Partnerships, and also the acute sector as well. And this has emerged as a result of some of the effective cross-system working that has been developed during COVID. So Home First has a variety of different priorities, some occurring at local levels and some occurring regionally. So we think about Aberdeen City, we obviously have our new care at home contract implementation. We have our stepped care approach, and there are a variety of pan-Grampian priorities that Aberdeen City are also taking the lead on. These are things like the redesign of our frailty pathway and the scale up of Near Me as well. And collectively, we're hoping that the cumulative impact of all of these is to positively impact on 3 big aims. This is around supporting early discharge back home, avoiding unnecessary hospital attendance or admission, and maintaining people safely at home. And I'm sure that the board can see that there are clear alignments between these aims of Operation Home First and Aberdeen City strategic plan, and the main aims around that, thinking about prevention, thinking about keeping people resilient, personalisation, connections and communities. So as I mentioned, there are a variety of priorities which fall underneath this Home First umbrella. And in terms of evidence and the impact of this, there are really fundamentally 3 kind of key phases. The first is mapping each of these priorities to the aims, so we can understand to what degree each of the priorities are likely to impact on each of the aims. We then need to have a much deeper understanding about each of the priorities individually. We need to understand what stage they're at. We need to understand whether they're occurring at scale, when they're likely to be implemented. And only once we've done this can we synthesize the cumulative impact of this. So as a result of this Home First portfolio, the 4 chief officers asked me to help them write a commission to evidence the impact of this portfolio in its entirety, and the details of which are embedded within the report. So I propose in the last slide just to kind of talk over the high-level conceptual evaluation framework, which as we speak is being worked through and developed up in more detail. So we've spoken about the portfolio, we've spoken about the key aims and identified some of the key priority areas. We've spoken about the need to map each of these priorities against the aims. And once we've done this, we can have a better understanding about what are the types of data infrastructure that we fundamentally need to put in place to evidence the impact of this. This is going to be a reasonably complex undertaking. It's going to likely span beyond some of the traditional data collection sources that we used previously, and there is likely going to need to be emergent and new data collection sources. This is going to probably move beyond our traditional counting of numbers and a lot more of a qualitative exploration as well, so we can understand from the impact of our service users, from our citizens and of our staff, the impact that these changes make on them. And there's going to be a variety of different measurement techniques, some of which are embedded within the report. That's going to comprise of your deep dive case study type approaches and to your higher level performance monitoring. And really fundamentally, the output of this is going to be 2 key things. The first one is going to be the development of a performance dashboard. This is going to be a meaningful performance dashboard, which after going through this systematic process and having a deeper understanding about each of the priorities individually, can we then understand, well, what would be the collective impact of them, and as such, the more meaningful performance metrics that we'd want to be looking at. And then the second thing we'll be looking at a synthesized report. This can help us understand about the individual components themselves, thinking about what worked well, what might we want to improve moving forward, and thinking about how we would like to potentially prioritize our areas of focus moving forward. So that was all I wanted to speak to you about, just to give a little bit of flavour into the broader context. And at this stage, I'm happy to open it up to any questions that anyone may have.
Okay, thank you very much, Callum. So, Councillor Bell.
Thank you, Chair. Callum, that was quite an interesting overview. I am interested actually in how the near me system works. I know, you know, it's for a GP, for instance, to actually visit a person virtually in their living room. But how does that physically work? What does the patient actually have to have available for this service to work?
So I can answer that, and then if I have extended colleagues that want to come in and add additional narrative, then that's fine. Basically, they need some form of internet connection, whether that is a smartphone or a laptop or something like this. Basically, they will be given a link to almost like an online platform, essentially, that they'll go on to submit their details, and then there's almost like a virtual waiting room whereby they see that clinician. So it's a reasonably standardized platform, and it can be used across clinical groups. So, for example, it is not just general practitioners that use this platform. There are a range of colleagues in both primary and secondary care that use this. So it's reasonably straightforward to use, and basically just requires an internet connection to access.
Thank you. So a supplemental question then. That's how I thought it would have worked. So what actually happens then if it's an older person? So in my ward, Lower D side, the Lower D side has the highest number of older folk in percentage terms compared to the rest of the city who don't have smartphones, who don't have computers. So presumably near me doesn't work for them, and they have to have a physical visit. So, you know, so in that case, be a bit like they do in Lothian, say, where the GP just turns up they don their PPE and they go in and do the examination. So is that's still presumably happening?
Yeah, so I see Alison's got her hand up, but I'll answer a bit of that first. So really, what we've been trying to do is change how people access services. So in the ideal situation, they use the telephone first when they can, in terms of having a conversation. If an individual is required to be viewed for whatever reason, then you'd use Near Me. And if there's a requirement for a physical examination, then that would be done in person. You're absolutely right. There will be particular cohorts of the population that this may not be appropriate for, and in those situations, physical examinations, if that's the most appropriate, are still being offered. There probably is a more fundamental question, and this may be a bigger piece of work, which is around elderly individuals and technology, and actually enabling those particular cohorts who maybe aren't as technologically literate as other cohorts to actually use them. But yes, those other avenues are still open. It's about really what's the most appropriate care for the appropriate person at the appropriate time. But I'll let Alison come in and add anything additional over the top of that.
No, Callum, I was going to answer along similar lines. You know, that Near Me is just part of that. You know, hear, see, feel approach. You know, if the GP or indeed any other practitioner or clinician needs to, if just hearing about a problem is sufficient, then the telephone would be used. If they need to see it, then we perhaps would use something along the lines of the kind of video link that Callum just discussed. But if they have to feel it, then it would be a safe physical appointment that's arranged for them. So I think you probably covered all of that already. But just in terms of the digital connection issue, it's not I guess it's just not about elderly people, although they do make up a cohort of perhaps our most digitally distanced population. But we also have the areas of deprivation to consider, people who can't afford internet connections or who can't afford devices, etc. And of course, we've been trying to address some of those issues through the Connecting Aberdeen project in terms of getting devices out to people who need them. So, but it is Near Me is just part of the bigger picture. It's not the sole focus for consultations going forward.
Thank you. I mean, it's a great idea. Do you, very quickly, Chair, if I can ask, so do you have any feedback from how effective it is from both clinicians and also from patients? In terms of, do the clinicians feel that they can do the patient justice? Does the patient feel they've been thwarted, inverted commas? I'm just curious.
So there have been various surveys done on Near Me since it has been introduced quite widely, and the feedback is all very positive. The only areas that have been highlighted are around, what happens if I don't have a device, or I don't have a device to connect, or I don't have a good internet connection, any negative points, if you like, that have been raised have been issues that we've already been aware of and are already working on doing something about it. So I think it's something that's been very well received by both the individuals and by clinicians that themselves. They're really welcoming it. It's given a huge flexibility to enable consultations to be undertaken, and it's actually created capacity as well. So I think it's been very positive from both sides. Callum, I don't know if you want to come back in on that particular point.
Yeah, the only thing I would just add to that is that you'll be aware yourself, people vote with their feet, and if they don't like something, they won't use it. And all of the all of the feedback that we've had in terms of comparing different health board areas, Grampian remains one of the highest users of Near Me across the country and has done consistently. And what that demonstrates is that it is an acceptable service to both people, clinicians and service users. And there is currently underway a large national evaluation evidence of the impact of Near Me, so we're going to be linking in with that and having a better understanding about the types of things that they're doing. But yeah, just to echo Alison's point, the feedback that we've had at the moment has been overwhelmingly positive.
Thank you. Yeah, that's me, Chair. Thank you.
You're on mute, John.
Oh, right. Sorry, Ruan.
Thanks, John, and thanks, Callum, for the presentation. I'm really supportive of the approach that you're taking, and really important to build in evaluation at the start, which is what you're describing, and the importance of qualitative and quantitative together. So I think the idea of having a dashboard that takes in both those is very good. A few questions just on that. So when is that likely to be developed and done? Are you looking at like March next year kind of time? Am I right in thinking that?
So in terms of some form of performance dashboard, we would hope to have something up and running in the winter. I mean, the caveat with that is that this will be an iterative process. We won't have a fully fledged final, sparkly, shiny dashboard at that point. And this will be something which will emerge, which will emerge over time as we develop and integrate new data sources. You'll know about all the challenges we've got with data. But so the immediate priority is that detailed understanding about each of the constituent parts and thinking about how do they feed up into the greater whole. So that's something that which we will hope to have probably by winter, and it will be a case of constantly refining that, given some of the caveats that I mentioned about, you know, new data sources having to link different sources of data and that sort of thing. But those are the timelines that we would be aiming for, yes.
Okay, okay. So just linked to that then, you talked about the importance of getting feedback from service users and from carers. Will there be an increased expectation on services that they should be really proactively getting feedback from people, considering people might experience services very differently? And I just wondered how that's been messaged to services and what support they're maybe getting around how to do that doesn't seem like an extra burden on people's, you know, busy workloads.
Yeah, so I mean, I suppose that's something, I think from the partnership side, that's certainly something which a lot of our services do anyway, because they understand that in terms of service evaluation and service improvement, one of the best ways to do that is through feedback from your service users. So a lot of what we'll be doing is integrated into best practice that we would do anyway. You're right, there is a tension about being pragmatic with this. So whilst we want to produce something which is very robust and something which we're very confident in, we also have to appreciate the stresses and the pressures that staff are under. And this is where the nuance and the devil's in the detail in terms of developing this infrastructure, which is incredibly simple to implement, which doesn't take a lot of time, but also adds a lot of value. So these are the conversations which we are beginning to have imminently about how can we integrate that, how can we build on what's already being done, and what can we do that will add the greatest amount of impact, but also the least amount of additional pressure.
Mm-hmm. Okay, thank you. And I suppose I've got loads of different questions, but my big question really is, it was really good to see the flash reports, and hopefully if we've got time we can speak about them in detail. But for me, and it's just what you're describing, we're getting lots of, it gives each flash report is a little bit of the puzzle, you know, it gives a little bit of the picture, and it would be helpful for me to understand what the assumptions we're basing our activities on now. So, you know, and I suppose in really basic ways, you know, we've got a 210,000 population, how many of them are over 75, and I suppose I'm thinking of the frailty pathway, and it would help me to understand things like, you know, we know we've got 25 beds at ARI, but so therefore how much hospital at home do we therefore need, and how will CTAC help that, and just map it, just give that overview so that we're sure that we're covering, we're not losing it, we're not leaving any patient group behind, and we're prioritising the right things now, based on what we know, which may change, of course, but just to, I think what I don't have visually is the modelling that we're basing our activities on right now. Does that make sense?
Yeah, I don't know if Alison or Alex you want to come in and respond to that.
Yeah, I'll try and respond, Luann. I absolutely understand what you're saying, and we was just in a conversation with Fiona Francie last night. She's trying to pull together a report for Pan-Grampian Operation Home First, where we're at just now, and funnily enough, we were talking about that we probably need to do a bit of mapping against the aims, you know, what each of the partnerships projects are, and what population it impacts on, and therefore have we got it all covered? I guess sort of take a step back from Operation Home First and bashing away at cracking on with the projects, but actually, you know, what does this mean? Have we got it covered, are there any gaps? So we were just chatting with colleagues in Murray who were wrestling with the same kind of issue, and they've started to do a bit of that work. So what I've suggested is that we kind of get together and do it collectively on a Grampian basis, but obviously that will that will impact on the city as well. So we may be able to bring that work back. It's at a very early stage, I would suggest. So I'm not sure how quickly we're going to be able to do that, but certainly Murray have started with some ideas, and I think we can build on that and use that for our purposes as well.
Okay, thanks, Alison. I totally recognise it's hugely complex and not an easy thing to do, but it's just when you see the individual flash reports, there's so many connects and so much of success of one area depends on another one working, that it's the big picture would give the assurance. Yeah.
Yeah, and that's exactly where Fiona was coming, because Fiona was she was tasked with writing a report, and she had all of the flash reports and all of the individual reports, and I think she was kind of scratching her head and saying, oh my goodness, how do I make sense of all of this? So that's where that has come from. So we'll see what we can do.
Okay, thank you. If I can have one final question, then there's other people I'm sure want to speak as well. I just wondered about the quality aspect of the changes we're doing and how much we're using national data around things like the Atlas of Variations, and just to give assurance that we're not becoming an outlier because we're delivering things differently. So are there Atlas of Variations that we can use to provide that assurance that we're still delivering services that are safely and effectively?
I think from our perspective, well, I suppose the short answer is yes, if that's appropriate. We've got very close links with colleagues from Public Health Scotland, and they've got a very strong overview of the national picture in terms of those national data sets that you were describing. So where possible and when we can link into them, then that's great. But we also recognise that quite often local contexts have localised priorities, and in some instances it maybe isn't appropriate to use those national data sets. But when we combine the national level and the local level, that gives us that much richer and that fuller picture about the overall impact. So short answer is yes, when appropriate, we will use national. When it is less appropriate and we need to develop something for a much more localised context, we'll do that. And it's about, like I said, it's the sum of those constituent parts that give us that overall picture.
Thanks, Callum. That's really helpful. Thank you.
Okay, thank you, Luann. Any other questions or comments on this? Okay, I'm not seeing anybody else signal. So if I can come in with one or two, just to clarify, Callum, you were saying you've been commissioned by all of the chief officers here. So is the piece of work going to report across the system, or is it going to report for Aberdeen City, or both?
So I think it can be both. If that would be helpful for the committee to be updated on progress. There is a Home First steering group which Sandra McLeod, sits on, along with the other chief officers across the other IJB areas. So this working group that's being created will report directly into that. But if the committee feel that reports into here would be beneficial, then that's absolutely something that we can do as well.
Yeah, I mean, clearly the report about the city is important, but given that a lot of this is on a cross-system basis, having sight of that, I think, would help us join the dots. So if people are in agreement with that, I think, given that it's going to be produced, it would be helpful for us. And can link to that, just to clarify from the report, at 3.2, there's the 11 transformations listed, and then at 4.8, it's got 4 of them listed as impacting on the city. So can you just square that for me?
Yeah, so the original 11 were the transformations that were embedded during the COVID period, and then the second list refers to those priorities which are currently ongoing. So some of those original transformations that were embedded are now essentially business as usual. and the following ones are continuing priorities moving forward.
And those are the ones that you'll be evaluating?
Yes.
The 4 rather than the 11. Okay. And then just a comment, I had a question which was along the lines of what Luann had asked, and so I think that is important for us in that kind of top line modelling. So I would just make an observation around that, which is, although it can seem a bit tricky, one of the ways into that is simply to ask, what are we currently assuming, i.e. making assumptions explicit, because we are spending money, we are intervening, there are projects that we are doing. Simply by asking what are the assumptions behind those actually surfaces the current modelling. There may be some gaps in it or whatever, but actually that's a very simple way into it, because it does exist even if it's implicit. So that's just a suggestion or a comment around that. What you've also got in the report, which is helpful, is looking towards the new strategic plan. So if I can just pick up on that, so we've got 18 months or so before a new strategic plan is in place. I'm assuming it's April 2022. Okay, that's fine. And so what you'll be doing is working in the meantime with you mentioned the local empowerment groups, but I think you're also intending to involve the other networks and community links with carers and various groups as well. Is that correct?
Yes, we're actually planning to start on that next month. You're absolutely right in terms of your timing. The current strategic plan runs until March 2022, so we should have our new one in place for April 22. And absolutely, our intention, our intended approach this time round is as much co-production as we can achieve. And obviously COVID and social distancing gives us challenges in that, but I'm sure we'll find ways around that. So we would be, in terms of a sort of a broad timeline for the next strategic plan, we would be looking to bring a consultation draft for approval to the IJB at its meeting, at its last meeting of calendar year 2021. So whether that's towards the end of November or beginning of December, Derek can maybe help me out. I'm not entirely sure what about the actual date of the meeting yet, but we would intend to bring a consultation draft to that meeting, which probably means we've got until about October to get that consultation draft prepared. So we're really down into the sort of 12-month planning period. So as I say, we're planning to start next month. We've got the strategic planning group obviously set up. We've got representation around that. As you mentioned, we've got the locality empowerment groups, which are really being very well developed at the minute, and we'll reach out into there. Our starting point is actually going to be our annual report. You'll have heard the discussion at the IJB recently around the annual report and the fact that we're looking at doing a little summary key messages document. So where the first stage is that we will take that round the locality empowerment groups and discuss that with them to say, how does that sit with them? Do they recognise some of the facts and figures that we've presented there, and try and get them to think about their priorities and the specific needs of their locality, and start that conversation, which hopefully will work its way across the 12 months towards, okay, so what needs to be the priorities for the partnership for its refreshed strategic plan. And absolutely, it won't just be locality empowerment groups that are involved in that. We will try and get as far and wide across the partnership as we can, using a number of already established groups. As you say, the carers group is a good example of that, but there are many other groups that we can use to ensure that we consult on that as widely as possible, and that the draft that we bring you for formal public consultation, if you like, next towards the end of next year, will be as fully co-produced, as I say, as we can make it.
Okay, thank you for that. And I suppose just one final question would be, it's really good to see what's proposed here in terms of the evaluation of what is going on, and then the way you presented that, looking towards the next plan, and you're going to bring back some work around what Luann had raised. I see that the synthesized report around the evaluation will be around about June of next year. So it strikes me that it might be helpful for there to be at least an informal session of all of the IJB members around that evaluation and where things are going in terms of the new plan, just so we can start to bring things together. I don't know if other members would find that helpful, and if officers have any comment on that. Callum?
Yeah, sorry, rather than just butting in, I was going to say, yeah, there's absolutely no issue with that at all. And whilst there might be again a formal shiny report in June, we will have findings which will be quite clear and evident prior to that we can bring along and discuss as and when they emerge. And naturally, this is going to directly feed into the refresh of the strategic plan. So if that type of session would be helpful, then we're more than happy to facilitate that.
Okay, thank you. And I suppose that's a suggestion. So we can maybe ask Luann and Sarah, along with the Chief Officer and Alex, to work out what's most appropriate in terms of timing and what's done there. Luann, did you want to come in?
Well, no, just to say, I'll pick that up when we're planning agendas and seminars and stuff, to get the most appropriate time for that.
Okay. You got your hand up? Do you have a question?
Oh.
Okay. Alison?
Yes, sorry, if I could just come in terms of the strategic plan, absolutely, we would be planning to involve the IJB at various points along that 12-month planning period. So we would probably be bringing back sort of reports on initial feedback, from some of these planning sessions, and perhaps some initial suggestions as to where we might think the strategic plan might go. At the minute, we've got 5 strategic aims. Perhaps there might be some early indications that we might either drop one of them or change them. So it's that kind of thing we would be checking in with the IJB all the way along the planning process.
Good. Okay, that's good. So any other questions or comments committee members would like to offer? Okay, Luann?
Thanks. John, it was just when I was reading the flash reports and the activity around the integrated access point, and then I was also reading the work around the stepped care model that's being developed, and it struck me, what are the connects between the two? Because is there, I suppose I'm thinking, are we developing a social model and a medical model, and are we developing them separately, or is there a sort of, I suppose I'm thinking they're both direct access points for the public, but one's about, getting help with access to groceries or whatever, and the other one's more medical. But is there something about the connecting the two of them into a single point, or is that, am I barking up a wrong tree there?
So I suppose there's a little bit of context. We've got Susie on the call as well, who's leading this stepped care work, so she can answer from that perspective. I mean, from the integrated access point, you're absolutely right. This is to do with a single point of contact for individuals living in the community. But this is not just for social care services. The scoping piece of work that is being done comprised of all of the delegated services to the partnership. So that's not just on the council side and also on the health side. And as part of that piece of work, it's about thinking, right, well, what phasing or is most appropriate to begin to try and amalgamate these together. From the stepped care side, not all of the services within that, for example, are ones that individuals might directly self-refer into. So, for example, if we have the hospital at home service and they're looking at to accelerate discharge out of hospital, that would be a professional referral in that instance, as opposed to a self-referral. So this is why I suppose it's particularly useful that Susie and I sit in the same team, so we can have these direct conversations about this, and we can make sure that there isn't a duplication or a contrast, I suppose, of work. Susie, I don't know if you want to come in on that.
No, you've actually given kind of a summary of it, but I suppose, sorry, excuse me, is that that is the difference actually. The integrated access point is for public access into it. The step care approach, although it is not just professionals, the majority of the work, as Callum's mentioned, around hospital at home, and also I don't know if you've seen the triangle, but the red and amber are both more around the multidisciplinary team, which includes our providers and includes, partnership in the biggest sense, but around health and social care to provide the rapid wraparound services for our individuals and patients in the community. So it's slightly different, but they are absolutely connected. So, and also the other thing to mention is step care is more around the unscheduled care. So moving unscheduled care into planned care. Not all the services, some of the services you can self-refer into, but that's not necessarily the purpose of the stepped care approach. So they actually completely align. So it's quite interesting you mentioned that. So again, that's maybe a demonstration of the flash reports sitting separately don't always show you the linkages. And we know that, but we maybe haven't communicated that well. Yeah, and as Callum says, we sit side by side, and all the projects we do align them, and we have huddles and conversations, and that's part of our kind of risk conversations, and I'm making sure that they are linked, but it's maybe not being demonstrated in the way that we're presenting that information. So I think that's a helpful question to ask, actually.
Thanks, and I think it makes perfect sense how you've described the professional kind of lead bit there, but it demonstrates, I suppose, the need for the big picture on the bottom, on the top of the jigsaw puzzle box that shows how everything connects up, and that we're not doing siloed work in, which would be the risk. But I'm very happy with your responses, so thank you for that. I did have a point on the integrated access point. Are we involving commission services in that as well? Because I'm thinking there will be some commission service that already provide direct access for particular care groups. So just again, I'm thinking about not doing that duplication working.
Yeah. Sorry, so I'll jump in there. So the one service that we have, one commission service at the moment that we've liaised with around this is Bonaccord Care, in terms of the sheer size of them and how much care that they provide. It was felt as an initial first phase, it would probably be I don't want to say easier, but in terms of making sure that it was partnership services, those would be the ones that, given in mind the complexity of this, it probably makes sense to start in-house. If we show that works and it's good and all that sort of thing, then we can see about how we would expand that out. But in this first phase, the immediate priority is those services that are within our remit, and the specific focus is on the services that you can self-refer into, and the services where self-referral is the primary route in, so it's how most people access those services. So that's the first piece of the elephant, if that makes sense.
Yeah, thank you. Thanks.
Thank you, Van. I mean, I'm not seeing anybody else signalling, so I think we've come to the conclusion for this item. So thank you very much to everybody who has contributed to that and presented on it. If we can go to the recommendations, we're asked to note the information provided in the report. Can I just suggest, Derek, that what we do is note, so this is just clearer for the public record of the minute, that we note the approach to the evaluation of the impact of Operation Home First, and note the plans for refreshing the strategic plan. Is that acceptable to everybody as a recommendation?
Yes, absolutely.
Okay, and to the committee members, you happy with that?
Yes.
Okay, that's fine. Thank you very much.
Yep.
So if we can go to the final item then, which is for confirmation of assurance. So from committee members, I can just ask if you've received sufficient assurance from the reports presented that we're fulfilling our duties. I'm assuming everybody's content. I don't think anybody's signalling, so
Yes.
that's the case. Thank you. Okay, well that brings us to the end of this meeting. Thank you once again to everybody for your contributions. Thank you.
Thank
Bye.
you.
Thank you.
Bye.
Thank you.
Cheers.
Bye.
Just
Thanks,
before
everyone.
we all disappear, Chair, I can just let you all know that there will be a report going to the IGB in October with a timeline of dates for meetings up till March 22, which will allow some of the timelines around strategic plan work to be put in place.
Thank you.
Cheers, Alison.
Thanks, Derek.
Thank you, everybody. Then. Bye-bye.
Bye.